And now I am honored to introduce CRAN's founder, president, and CEO, Filomena Servidio-Italiano, who will provide the president's welcome and highlight a patient's story. Filomena exudes an unmatched passion for and dedication to improving cancer patient outcomes by way of quality of life and longevity. I consider myself to be quite privileged to call her a colleague, a mentor, and a friend. Filomena's vision and drive inspire our team at CRAN each and every day, and I truly believe that the cancer care landscape in Canada is better in part to her ambitious nature. Filomena truly keeps the patient perspective of everything that we do at CRAN as we provide patient-focused and evidence-based support, education, and advocacy for cancer patients across Canada. And with that, Filomena, I'll pass it over to you.
Thanks very much, Cassandra, for that lovely introduction. You actually brought a tear to my eyes. Well, good morning, my friends, and a very warm welcome to our third annual Biomarkers Conference. It's a glorious day to be hosting a conference focusing on comprehensive genomic profiling, or CGP, in the Canadian healthcare landscape as we seek to overcome challenges and embrace opportunities for a path forward as we acquire a greater understanding of CGP's utility in the management of metastatic cancers. The entire conference was inspired by our metastatic cancer patients' relentless pursuit to learn as much as they possibly can about CGP and its application in the metastatic disease setting. But there was far more that served as the impetus for the scheduling of this year's conference, not the least of which were, firstly, the compelling results and issues that we identified from the National Pan-Tumor Survey we led in 2024 across 24 cancers with respect to CGP access, its lack of funding, barriers, and challenges reported by patients and caregivers. Based on patient feedback, patients believe CGP may provide value with respect to therapy selection if an actionable mutation is identified. Secondly, CGP is providing the opportunity to identify cancer mutations in multiple tumor types and permitting access to existing therapies for new tumor types. However, these off-label therapies can only be accessed in the clinical trial setting or as an out-of-pocket expense. And thirdly, for patients wishing to gain access to this diagnostic to help inform management of their care, patients in Canada are facing several barriers. There are social determinants of health, factors like socioeconomic status, geographic location, and access to transportation that can affect a patient's ability to access CGP. And so many other barriers and challenges, including limited awareness among clinicians and patients, lack of standardized testing protocols, and inconsistent access across different provinces and healthcare settings. We already have evidence of this diagnostic tool increasing overall survival and reducing the number of toxic events, side effects suffered, and adverse outcomes by patients undergoing systemic therapies. And it is able to do so by detecting the genetic alterations of hundreds of genes simultaneously in just one test. In the personalized medicine era in which we currently find ourselves, CGP is now being used for cancer diagnosis, treatment selection, and prognosis prediction, and our metastatic patient populations are seeking out this diagnostic specifically for the purposes of treatment identification to help improve longevity and quality of life, especially for those difficult to treat cancers. To that end, allow me to introduce you to a metastatic colorectal cancer patient and healthcare provider, Dr. Lisa Dickson, who, at the age of 42, Lisa, a young mother and wife, was diagnosed with stage 3 sigmoid colon cancer in July of 2023. Lisa's advanced biomarker testing results revealed she has a rather difficult genetic mutation, a BRAF V600E mutation. Nevertheless, at that particular time, she underwent a resection of her colon, uterus, and bilateral oophorectomy, the removal of her ovaries, followed by 3 months of combo chemo, CAPOX. She was apparently no evidence of disease right up until January of 2024. In May of 2024, they discovered metastatic disease in her peritoneum. She had CGP ordered, which was performed in New Brunswick. It revealed a PIK3CA mutation. Knowing she has a difficult to treat BRAF V600E mutation, she started a targeted protocol to help address that mutation that was driving the growth and the spread of her disease, consisting of encorafenib in combination with an anti-EGFR therapy. She noticed progression over the course of 6 weeks, so they added combo chemo, FOLFIRI, to the encorafenib and anti-EGFR therapy based on some preliminary evidence in the literature, and then she noticed some tumor stability, which was fantastic. In July of 2024, she had more CGP done, this time through Guardant 360, which tested hundreds of genes to help inform the management of her disease. It confirmed the previously generated CGP panel results in May of 2024. In October 2024, seeing that her disease maintained stability, she had a rather aggressive surgery and HIPEC, which was the heated bathing of the abdominal organs, to address any microscopic disease left over after the resection of her peritoneal metastases, after which she began the process of personalized immune vaccine therapy, 3 doses of Keytruda every 6 weeks. Unfortunately, Lisa suffered a recurrence in January of 2025, so she started the encorafenib and anti-EGFR therapy and FOLFIRI all over again. And then in April of 2025, she received her first personalized immune therapy in Germany, which brings us to today. Good morning, Lisa, and a very warm welcome to you.
Good morning. Thank you for the introduction and summary of my last 2 years.
We are truly, truly delighted to have you participating this morning, Lisa, to chat a little bit about your journey and how CGP played a role in that journey. I essentially have 3 questions for you, Lisa.
Mhm.
The first of which is, in 1 minute or less, or just about, can you please share with us, Lisa, how you felt when you received a diagnosis of metastatic colon cancer?
Sure. Well, I was devastated. I guess to put things in sort of perspective, when I was diagnosed in July 2023 with the stage 3 colon cancer, I actually felt a relief. I was sick for so long and feeling miserable and didn't have any answers that even though it was a cancer diagnosis, I thought, oh, I breathed a sigh of relief. Like, okay, good, we're going to treat this. It's stage 3, we can get it out, get it gone, and I'm going to move on with life, which turned out not to be the case. So I was mid-clinic when I got the call in May 2024 to tell me that my recent CT scan showed metastatic recurrence in the peritoneum, and I was devastated. I cried and I canceled the rest of my clinic, and I just knew at that point probably my life would never be the same again. Awful.
And we truly feel for you, Lisa, because you are a young wife and a young mother. And so I can't imagine what that must have been like for you and your husband and your little one.
Yeah. Yeah. Pretty devastating for all of us.
So, our next question in 3 minutes or less. How did biomarker testing in CGP help to inform the management of your metastatic cancer? What was that like for you?
I would say that's been a bit of a journey. I did get initially at my first diagnosis some testing that showed the BRAF mutation. At that time, I don't think it changed or sort of directed any care. I got the standard K-pox. But when the recurrence happened in May, it definitely played a role in starting the targeted therapy against the BRAF mutation. So I started on the encorafenib and EGFR inhibitor, hoping and really hopeful that that was going to do the trick. And I really had no side effects from either of those drugs. So I was just sort of thrilled that I had this targeted therapy that was going to work for me. Unfortunately, it didn't, as you mentioned. So we added on the full fury and found some stabilization. With the addition of the Guardant 360 and the testing that was done in New Brunswick and the testing that was done in Germany, we did find the PIK3CA mutation, which led me to a short course of aspirin, which was I guess has been sort of in the literature or debatable for quite a few years, according to my oncologist. But there was sort of a newer information at a recent conference that that may help prevent recurrence and what have you. And I thought, what the heck, we're going to do that. I have the PIK3CA mutation, but I did have some bleeding, urinary bleeding. So we discontinued that, but that did also direct management. I'm not sure where I'm at with my minutes, but one of the things I just wanted to mention is that the testing in Germany was revealing in hindsight because they also not only identified targetable mutations on my tumor, but the frequency with which they were presented or present on the cell. So, and the BRAF mutation is only found in 50% of my tumor cells. So it kind of gives information as to why the BRAF treatment targeting that alone didn't do the trick. But that's the beauty of hindsight, I guess. But if I had known that information earlier, we probably wouldn't have just done targeted therapy for those 6 weeks.
Excellent. Thank you for sharing that. That's very helpful, Lisa.
Yeah.
And your last question,
Yeah.
and you do have 4 minutes for this. If you could make a recommendation to public policy experts regarding CGP, what would that recommendation be?
Undoubtedly, I would recommend that we ensure that every patient has access to this information early so that we don't find out things after we've treated them with something that clearly isn't going to work. I know we're aiming for, with this conference, stage 4, Filomena, we've talked about that, but it would be helpful for even advanced stage 3, and we'll get to that in years to come, I'm sure, or in future endeavors. But for sure, for all our stage 4 patients, it can reveal actionable mutations, treatment options that we would otherwise might miss. It can definitely make a difference between having a chance and running out of options as your disease is progressing. You think you're being treated. You know, had I known that BRAF information earlier, we would have done things differently. I think it should be a standard part of care. I think personalized cancer care is an absolute must. I have never felt more like, sorry, I don't know my chemo brain here.
You're doing great. You're doing great.
Just, I feel like I'm just a point in a flow chart generally, or I have felt that way. I have this diagnosis, and so this is what I'm going to get. If this were, I just feel like I'm in a flow chart, and that's not the way we need to treat this. We're doing it so backwards. Um, I don't think patients should have to fight or pay to get this testing done. This should be a standard part of care covered by our provincial plans. I think patients are fighting for enough. We've got enough on our plates trying to fight for our lives. We shouldn't have to fight for the right treatment.
Thank you, Lisa. Thank you. Thank you for joining us today and sharing your lived experience. I know I speak for everyone when I say that we wish you the very best in your journey.
Thank you.
Ladies and gentlemen, we have an absolutely spectacular day carved out for you today. One of the most anticipated sessions, among others, is the Conference Board of Canada's presentation on the cost-benefit analysis findings generated to help support access to CGP in Canada, a report that was commissioned by CCRAN. I can't wait, my friends, to hear these compelling results. And of course, our day is filled with insights that will most surely interest every stakeholder, be you a patient, a caregiver, pathologist, industry leader, clinician, or policy expert, for we are delivering an agenda focusing on policy and advocacy to support the implementation of CGP for patients with metastatic disease in Canada. It is, however, very much patient-focused, so sit back and enjoy. Back to you, Cassandra.